Hi everyone, we're going to discuss the bedside evaluation using ultrasound for the deep venous thrombosis or DVT. We're talking about the subject for several reasons. Primarily, lower extremity DVT is the primary cause of pulmonary embolism or PE. The CDC estimates around 900,000 people a year are diagnosed with a DVT or PE, and up to 80,000 a year die from this cause. About 25% of those fatalities appear as sudden death as the primary symptom. Primary pathophysiologic reason for this is blood clotting inappropriately in the veins. The main risk factors were described in the 1890s by Rudolf Virchow. These include a stasis of blood flow, vascular injury or trauma, and hypercoagulability. These are very broad categories with a lot of implications. Venothromboembolism remains a great masquerader for common complaints such as skin infections, poor circulation, dependent edema, and musculoskeletal injury. Prior to the utilization and improvement of ultrasound diagnosis would require venography, where the femoral veins would have to be directly injected with kidney toxic contrast in hopes of catching an area of flow deficit. Clinical exam alone is highly inaccurate as there is much crossover between various complaints and normal patients without DVT. In 1995, the Wells criteria was developed to help clinicians decide if they needed to pursue the diagnosis or if they could order a one-way rule-out test called a D-dimer. This test is looking for the breakdown products from blood clots. It is also an acute phase reacting to any bleeding process or inflammatory process. Therefore, if it's elevated, it cannot exclude DVT, but if it's negative, being that it is highly sensitive, it could rule it out. This table is on the criteria reflecting various proven factors known to increase the risk of developing DVTs. Ultrasound has emerged since the late 1990s as a diagnostic modality of choice. However, access to vascular lab studies, even at our own institution, is limited based upon hours of operation and does not take into account transportation issues or provider access issues preventing patients from getting these studies done. Point-of-care ultrasound has started to gain traction with a large literature basis demonstrating potential for highly specific and moderately sensitive results. The anatomy of the leg that is most at risk for DVT is the areas of high turbulence and the potential for agitation of blood and cause platelet activation forming a clot. These areas are at the branch points. For the sake of discussion, we're going to focus on a two-zone compression technique and review its limitations and uses. The first region is the femoral region. It includes the common femoral vein, the saphenous branch point, and the splitting of the deep and superficial femoral veins. The second region is the popliteal region behind the knee and includes the upper border of the fossa down to the lower border and the trifurcation of the veins as they start to become calf veins. The probe of choice is the linear high-frequency probe. The region is scanned at a short axis with the probe marker oriented toward the patient's right side. Gentle pressure, enough to start tenting the corresponding artery, is applied until the walls of the vein collapse and touch completely as shown here. If the walls are unable to touch with compression and or a solid structure seen within the veins, then the exam is considered positive for an obstruction, likely from a clot. Acute clots appear dark and look the same as blood on ultrasound in the vessels, while older clots start to become more white or solid in appearance. Next, we move to the popliteal region. This region is behind the knee, and we start at the top of the popliteal fossa and apply gentle compression as we walk down the vein until it branches into three calf veins, and compress this area as well. The popliteal vein is always on top of the artery, or as we call it, pop on top to help your memory. This is an example of a clot in the popliteal vein. Notice the lack of compression on the popliteal vein being on top of the artery. You do not see the actual clot itself because it is likely relatively new and anechoic. How well do we trust our bedside ultrasound compared to vascular lab ultrasounds? Originally, we thought this was quite amazing and the literature coming out was a bit too good to be true. Studies started coming out using residents and students with only brief training, and the numbers got worse. They were about as sensitive as a coin toss. When there was a large clot, they saw it about 90% of the time. So a lot of physicians shied away from the exam for a couple of years. However, a much larger randomized and blinded trial came out in 2015 demonstrating that two-zone approach in 2,000 patients combined with a D-dimer was able to avoid radiology visits and more testing in most patients without missing any large clots that went on to become pulmonary emboli. Patients with a positive D-dimer could also have a follow-up study performed in about a week to check for isolated clot propagation, and this was found to be safe without any complications and only a 5% rate of clot being discovered if the bedside exam was negative and the D-dimer was positive. More recent studies in the UK showed this was a viable option for general practitioners and family physicians who had difficulty getting radiology studies performed if they went through a 2-month training process involving 16 hours of training. They had a 90% agreement with the radiologist performing a repeat study within days and were 97% specific and 92% sensitive. So the question is, how will this apply to your practice? If your patients are having surgery, seeing you in follow-up clinic, coming to your office with a history of cancer, have leg pain and/or shortness of breath, the visualization of DVT with concern for PE can diagnose that condition and potentially avoid radiation from angiography. It can help diagnose a cause for hypotension in a coding or peri-arrest patient doing poorly and change the course of their outcomes. And it can close the gap between the time to diagnosis and initiation of therapy, which has some benefits in preventing further clot growth and embolization. This is a skill that requires some training, likely greater than 20 minutes but probably less than 16 hours, and can rapidly be applied at the bedside to determine and course correct a potentially life-threatening condition. Look forward to seeing you in lab, and don't forget the pre-lab quiz.